All right, can you hear me now?
Much better.
Oh, we can hear you. So apparently when you test the audio, it doesn't actually join the audio, it just tests it. All right. Well, good. They didn't hear me insulting them. Okay. So basically this guy comes in, respiratory failure due to COVID. He worsens. It's time to upgrade to mechanical support. What do we want to do? Protec or Crescent? So this is what view is this? We'll start by just naming the view.
The esophageal four-chamber.
Mid-esophageal four-chamber. It's a little bit swung to the right. So here's our, here we go. LA, LV, RA, RV. Okay. What do we think so far? Because when we're trying to decide between a Crescent or a Protec, kind of what are one of the things we're looking at?
RV looks okay.
RV function. Okay, yep. So this is, if you think about like with a transthoracic, this TAPSE right here looks like it would be pretty good. Not sure about the base. All right, we'll keep going. All right, what is this view?
Mid-esophageal long axis.
Yeah, mid-esophageal long axis. So this doesn't give you any right-sided information, but I thought I would just include it. So LA, LV, aortic valve, you can see the RV kind of right in here. What do we think about this one? Because I guess if the LV is really bad too and you blast it with a bunch of blood, it might not tolerate that also. So always good to do a full exam. What do we think function-wise? Yeah, looks okay. All right. And now what is this view? So usually this view is obtained at about 60. So we're a little beyond that, but that's okay. Okay. Yeah, so this is your esophageal RV inflow outflow tract. So up here is going to be your RA, your RV, and then going into your PA. Your tricuspid's probably around here, and your pulmonic, I think you can see whiffs of it right here. So it's another view to see how well the RV is squeezing. What do we think? Looks okay. And remember that even if there is a little bit of RV dysfunction, if you improve hypoxia, things should get a little bit better. And then lastly, and all these pictures are real. You can't always pick perfect patients with perfect pictures. All right, what view is this?
Transgastric short axis.
Yeah, so your transgastric view, mid-papillary view. And you can see this one can be useful when you're looking for, is there like a D-shaped septum, either diastole or systole. Thoughts? Any concerns? No. All right, so what device are you guys going to recommend? Okay, Crescents. So the one that does not provide RV support. Your patient's doing well. 2 weeks later, they're having increased pressure requirement throughout the day. Norepi's up. Their SATs are starting to sag. They're 100% on the vent now in the circuit. He's already heavily sedated and does not appear to be fighting the ventilator. What are some thoughts that could be going on? He could be septic, right? He could have some new pneumonia on top of things. Could be septic. What else do we think? Hypoxic, increasing pressors. Could be going into cardiogenic shock. Could be going to cardiogenic shock as well. So yeah, so kind of when you hit all your things, right? You could be going into septic shock, as he's getting more hypoxic and you're going up on sedation, that could be contributing. As you mentioned, right, he could be going into cardiogenic, either RV, LV, could have worsening pulmonary hypertension. You assume he's anticoagulated for his device, but PE is always an option, especially with hypoxia. And then hypovolemic potentially if you've been slamming him with diuretics and he's getting a little sepsis now and bleeding. And then lastly, anytime you have a device patient, you could always have cannula malposition. So how do you help determine between some of those things?
I could do a couple of things. You could always put a swan in.
Okay.
That's the old school. Good luck with cardiogram.
Yay! You can put a TE probe in. Actually, device patients are most of the time I use TE probes in the unit because otherwise I have no idea. All right, so you throw a probe in and this is what you see. So this is, again, we're back at our 4-chamber mid-esophageal view, and what do we think? And we must have been short on probes this day because this is the terrible probe in the unit. How do we think that RV looks in comparison?
Sad.
Not happy.
Yeah. So actually, it looks like there's a little bit of, there's still somewhat decent movement of this tricuspid annulus, but you can see it's much bigger than the LV. And at most, the right side should be at most like 2/3 the size of the LV. So you have a big RV and then underfilled LV. And then also, if you look at the septum here, is it midline or is it bowing? It's bowing. So that kind of shows that there's a pressure overload on that right side. Actually, this doesn't look too bad. But this was the guy. And like I said, I always sometimes think this picture looks better than the 4-chamber view. So this is that again, our mid-esophageal RV inflow, outflow. And you can see the RV actually looks like it's squeezing, not so bad. And then we go, well, this is just impossible to see up here. But if you can make it out on here, and again, this is the really bad probe in the unit. So here's the tracing. So this is a transgastric view. Here's your LV, and this is your RV over here. So you can see much bigger compared to the LV. All right, so we already know what's going on. So what would you like to do? What do you think this, or what would you like to do with this information?
Call Buck.
Okay, so you can do a ProTech. That's going to take some time. What can you do in the interim? Yeah, so you can, exactly. So you can do that. You can start some inhaled EPO, just something to help temporize while you get to the OR. All right. Case number 2. So this is a 62-year-old gentleman. And he comes in through the shot call system. And this is the blurb you get about him. And you can't access care everywhere. There's no info in care everywhere. So basically this guy comes in with dyspnea. He has an AKI, leukocytosis, lactic acidosis, and his tropes are up. He was also an AFib RVR. They did a CTPE. He had bilateral PEs and possible RV strain on his CT scan. So they actually took him at the outside hospital. They did a pulmonary embolectomy. And during that procedure, he decompensated. He needed to be tubed. He needed pressors and inotropes. And they put in a balloon pump. With that kind of stem, what kind of person are you thinking you're getting? Well, a sick person, yep. Yep. That's right. You have like an hour or two to just kind of think, what kind of patient am I getting here?
Pulmonary hypertension, acute RV failure.
Okay, so maybe some RV failure with the PEs and decompensating. So he gets here, he's tubed. You decide to figure out what's going on. This is what you see. All right, what are your thoughts? Does it completely match with what you were envisioning? More like biventricular failure, okay. And would biventricular failure be explained by kind of the story you got?
No, that,
No.
like I said, way more.
Yeah. All right, this is your next, and then what view is this? Two chamber, yep, mid-esophageal two chamber, so it's taken at 90 degrees. And this is your, just a picture of your LV. You can see a little bit of the appendage sneaking into view here. Does anyone remember what wall this is?
Anterior?
Anterior, so anterior wall by the appendage. They're all anterior structures, start with an A. And if this is an anterior wall, then what wall is this? It's not posterior, inferior. Yeah, it's got the weird nomenclature. So yeah, what do we think for thoughts for an EF? Just eyeballing this.
Zero?
Yeah, everyone's laughing. So I think we all know, very poor. You can take the easy way out and say less than 20. All right. And then this, what view is this quickly? Long axis, yep, mid-esophageal long axis. Has this changed your mind about anything? No. And then, because this isn't. This is our mid-esophageal RV inflow outflow. You can
Same additional.
same, yeah, same. Everything looks poor. And then we're gonna go down to the stomach. It's not moving. All right, so let me try to see it. Let me see what I have here. So this is what, so you have those pictures now. These are your vitals. And remember, you do have a balloon pump at 1:1. All right, so that's, so you're like, you're marginal. You're doing okay. You're on these drips and you got your balloon pump. All right, what's your assessment or what do you want?
Well, assessment would be this patient has what seems to be sort of acute biventricular failure. Unknown origin of this explained.
And then lastly, always, what would you like to do? This came in, Adam, I don't know if you were in the unit the last couple weeks. This came in the last time I was on nights, just a couple weeks ago. These people always come in on nights, I feel like.
Yeah. It's the word, yeah, I think they try to do stuff during the day and then
Yeah.
when things fail. it's like,
I guess it'd be nice to know, what the etiology of all this
Yeah.
is. So maybe the calf,
You might need to be cathed.
like septic cardiomyopathy, needs to get full infections workup.
You pan culture, okay.
I would guess I'd throw in a CTP same time.
Yep. Oh, I forgot to mention, I forgot to put the clip in there. I did get a clip where you couldn't see any PE in the right main anymore. I should have thrown that in. I forgot. Yeah, well, and the nice thing actually is family showed up. He's not been able to move more than 10 feet for 2 months. So my thought was then, do you think this is an acute drop in his EF? No. Yeah, so this guy had chronic, he either had some ischemic event or something, and basically his immobility from his heart failure probably led to a DVT, which spiraled into everything. Now, here's the thing. So there's all your because we're in the CVIC, we always think, would you like to upgrade this patient's mechanical support? Given everything that like this. So maybe. So one thing I did not bring up, because I actually missed it the first time I took these pictures.
thrombus.
What do we think this is right here? Yeah. So that's actually a pretty nicely laminar LV thrombus right there. And I was so shocked by his terrible EF. I completely missed it on my scan. Luckily they had somewhat seen it on the CTPE and we got a T, but this right here is going to be all thrombus. So a lot of times we think of thrombus as something that's like waving or that's like really kind of not, pokes out and doesn't mesh kind of with the myocardial borders, but that right there is just thrombus. You can see it right probably here too, which limits a lot of your options for circulatory support. So yeah, if you see something that just kind of looks like, it doesn't look like your picture's foreshortened, but just in one area it does, it could be a thrombus. And I should have included the TTE pictures, but when they use contrast, it's really easy to see because you're just like, oh, there's this weird little filling defect right in that area. So yeah, this guy actually did okay for a while and then he came back and coded and died. So, but he had a bad heart.
And he remained unavoidable.
Yeah. He was having some VT at the other hospital and there too, but I didn't want to make the case more complicated. All right. Case number 3, 65-year-old man. He came from the floor to the CVICU after having some sun visual defects concerning first stroke. He was on the floor just because he had worsening heart failure and he was getting worked up, put on the transplant list, stuff like that. When you think CVA, given that this is a TE lecture, what are some things you think about? LV thrombus, okay.
Could have gone to AFib and from.
Okay.
Like that.
Yep. What other defects in the heart can lead to a stroke?
VSD, ASD.
Okay, so if he's got a hole in his heart somewhere too. All right, and then all the usual things that can lead to a stroke. All right, so you put the probe in. This is what you see. Remember, he's getting worked up for a transplant. So first of all, what is in this man's past medical history that you can tell just from this? Okay, so he has heart failure, but I should say surgical history.
Is it a mitral valve something?
Yeah. So if you look here, so this is the 4 chambers. So this is a mitral valve right here. And we'll look at it in another picture here. And then we'll determine if it's bioprosthetic or mechanical. All right, so we throw some color on there. That doesn't look terrible. All right, we switch over to, this is going to be called a 2-chamber view. All right, what kind of valve do we think this is? Bioprosthetic or mechanical? If you had to guess, 50-50.
Bioprosthetic.
Bioprosthetic, yeah. So if you can see leaflets, they're not, granted, they're not opening well, but if you can see leaflets, it's bioprosthetic because all the mechanical valves have mechanical like slits, kind of that just rock like that. The other thing is that, do we remember what this artifact is? When the beam comes down, hits here, and just reverberates back rather than coming through and you get this dropout. Actually, did I just say what it was?
It's dropout.
Yeah. With the mechanical valve, because the leaflets are also metal, you'll actually get, instead of this, how this is pretty fixed because it's right on the strut, with mechanical leaflets, you'll actually get that artifact that swings because it'll change as the leaflets move. So that's another key to look for between bioprosthetic and mechanical. If you saw a swinging artifact as the leaflets open and closed, it clues you in that's more mechanical. All right. But even a bioprosthetic valve, you can see all that dropout makes it hard to visualize. Okay. Here's another view. This one's kind of jumping into the long axis view.
Pretty sure I wrote a case report on this page.
You might have.
I pulled up.
Anything that looks out of the ordinary as you're scanning through this. It's okay if you say no. That's why you do a full exam. Something case reportable. All right, we're gonna keep going. Here's some color.
So right underneath where the aortic valve is coming off, looks a little odd.
Okay, so you're pointing at like this right here?
Yes.
So what do you think that might be?
This is the two view or the.
It's it's more in a long axis view, I would say, even though you're only at 103.
RV underneath,
That'd be RV underneath.
or maybe the BSD is.
Maybe. You're not getting color flow, and remember you're getting this dropout artifact from this strut right here, right? So this is a really shiny, reflective material, and the ultrasound beams probably aren't getting past that. But something you'd want to interrogate in other views. Okay. We're gonna keep going. What about this? Is this the one you did case report? I'm gonna ask you, I have another case that might be a good case report. All right. Yeah, so it's weird. We're at 0 degrees. So usually the RV inflow outflow is closer to like, even there valve and short axis is like 30 to 60, but this, when you have big, boggy, dilated hearts, you tend to get things at weird angles. All right, does anything look awry in this view?
The left ventricle on the top, right?
So this is gonna be your RA, tricuspid RV. This is your intraatrial septum, and then this is LA.
So. Maybe I'm. weird, But LA looks like it's full of a bunch of stuff that should.
Yeah.
Maybe blood.
Yeah. And so this is actually clot.
Okay.
And when you go even further,
Definitely.
so this is just zoomed in and turned a little bit. So to orient you, this is the RA down here, aortic valve, and this is just zoomed in a little bit. And this is your LA. And this man's LA was like completely filled with clot, with just like a tunnel from the pulmonary veins to the mitral.
Did he have AFib or some sort of?
I think it's because he just had terrible heart function, and then that
Slow that it just.
and then that bioprosthetic valve just,
Nitus.
yep. All right, and assuming this patient's hemodynamics worsen, how would you support him? This was one of our actual guys in the CVICU, because of course it was.
Yeah.
Thoughts and prayers. I don't know. I mean, like,
Yeah.
put much support in for him? I don't think so. Right?
Yeah, because if you put an Impella in, you have the risk of it showering. I'm gonna say this guy did get an Impella at some point, though.
I can't remember. I just remember when you first time I was supposed to go back to the OR for transplant, he stroked me.
He stroked it, yeah.
Yeah.
I think he ended up getting a balloon and just some inotropes, and that was it. So. All right, what's this next case? Oh,
Did
this
you
is,
ever make it to transplant?
Yes.
he did. Yep, he got transplanted. So
He
they,
was alive for a while. I called him.
he was still alive when I was.
Yeah. Yeah.
How bad was the stroke?
It was like a
It was
few
really
days.
minor. He had like one little visual field
Mhm.
deficit, and that was it. All right, I don't think I've used this one before. So this is a 6-year-old female. All the things, and she came in for a cabbage. It was pretty uneventful. So she comes out to the unit on the usual propofol, Precedex, and a little whiff of norepi. Your pressures are a little soft when she arrives. Index is low. And on top of that, your chest tube output is about 75 mils every 15 minutes. You get your sign out, your norepi's rising, your index remains poor. Not only that, your temperature's 34.7. Again, this is a real patient. What do you, if you had to guess, what do you think's going on? Or what would be your differential? Reported normal by V function in the OR.
I mean, with that test tube output, that's sort of concerning.
Yeah.
Issue going.
Okay.
Just hemorrhage.
Yeah, just bleeding, right? She just seems like she's bleeding.
Temperature is low, so these hyperchloremic.
It's not helping you. Yeah. All right, so these are all the things that can happen after cardiac surgery, right? You can be bleeding. I guess hypovolemic, you can just also be hypovolemic. Things to think about, grafts being down. If you had poor myocardial protection during bypass, tamponade, pneumo, half the time They don't put right, I mean, most of the time they don't put right plurals in. They never get in the right plural, and then you get your chest x-ray and they got to write pneumo. Vasoplegia, sepsis would be a little weird, but if they were in the hospital beforehand, all things. So for this person, you know, she's bleeding and she's cold. So you do the things, you give volume, you transfuse, and you warm the patient. You're happy, she's normothermic, her chest tube is now 50 an hour. Norepi's coming down. You go write your note. You're happy. But then 20 minutes later, the norepi has quickly escalated to 0.24 mics per kilo per minute. Now what?
You didn't tell you before that.
Nope. It was quick. It was, you know,
Any,
has that never happened to you in the unit,
that's
Dustin?
true. It's not one thing. I go reassess.
Okay, you reassess.
Look at the chest tube, make sure that's not, you know.
Yep.
Anything crazy.
Little 50 mils per hour. No deep in sedation.
For OTD, no.
Yay! All right, this is what you get. So half the time when you're trying to figure out what's going on and you put the probe down, I look and I go, I have no idea what I'm looking at. And then you have to try to orient yourself. All right, so in this case, what do you, or what view should we be seeing if you put the probe down and you're at 0 degrees? Because most things, I mean, a lot of views are 4-chamber, okay. You could also be in the stomach, right? So you could be seeing like a mid-pap view if you were really deep, or you could be seeing really high up on the aorta. So kind of knowing those things, okay. So if we think this is a 4-chamber view, what are things that can help us identify what we're looking at? Okay, some valves. So what valve do we think we're looking at here, if you had to guess? Mitral. So that would make this the, yeah, the left side of the heart. And then what do we think this is right here? Yeah, so if that's the septum. So that would make this the RA. And that would make that the crushed right side of the heart. Yeah.
I mean, the thing that looks abnormal to me is on that, like right there.
Yep.
That just looks like blood that's smooshing the right side, and it's like the septum is completely moved over.
Exactly.
Atrial.
So what do you think's going on?
Yeah.
Tamponade. The blood was coming out, and then the blood stopped coming out. And you can see, so where do you think that turbulent flow is?
I mean, it looks like it's between the RA and RV, so we're trying to.
Yeah, you probably have turbulent flow because it's just all being completely smushed. And now what view are we probably looking at here? And remember, everything's going to be a little distorted. Yeah, so RV inflow, outflow. So you know that this is your aortic valve here, and then you know probably what this is based on the last picture. So that's probably your intraatrial septum bowing way to the left. And that's, so what would that right here be? You can kind of see it. Tricuspid. And then what is all this? Clot. And if you look down in the chat or down in the mid-pap view, you can see here, your EF's like almost 100%, right? And that's just because no blood's getting over to that. Exactly. I thought I had another picture, but never mind. All right. So what happened? We all kind of know. Tamponade. What does this patient need? Yeah. Well, they're going to call the call teams in. What do you do to temporize the patient?
Let's give them a bunch of fluids.
So you can give them fluid. Yeah. Oftentimes you have a pacer, so you can see if pacing them a little higher helps. But yeah, give them some fluid.
Hope for the best.
Try to pace them a little faster.
That's right.
And if, yeah, and if things get bad, worst case scenario, just give them a little space yourself. So luckily I've never had to do that. So, all right, what is this one now? This is the one that might be a good case report. All right.
Oh, nice.
So, case 5, 77-year-old female. She has mitral stenosis, aortic stenosis, and she underwent a high-risk double valve procedure. The post-op course was complicated by an ASD iatrogenic. So oftentimes they do make an ASD when they replace the mitral because they go transeptal and then they repair it. Yep. It was complicated though. She went into shock with that ASD. She needed emergent repair and she got put on central VA ECMO. So she arrives after having gone back to the OR for VA ECMO. She's intubated, sedated. She's on the drips you would expect, and she's bleeding. And just for those that don't do a lot of ECMO, so central ECMO is you're cannulated in the RA usually, blood is going out, and then it goes to the pump and it comes back and directly into ascending aorta. The patient has about 15 millimeters mercuries of pulse pressure on arrival, but this slowly declines over the first 5 or over the first hour to less than 5. So remember, just for those that don't do a lot of central ECMO, so you're sucking blood from here and you're putting it back in here, but there's always going to be some blood that continues to go through the heart. The ECMO circuit's not going to capture all that. So a lot of times they do have some pulse pressure, which is good because that shows that the LV is ejected. So if it drops to less than 5, what are some of the things you're thinking of? Why would your pulse pressure drop?
Hypovolemia.
Hypovolemia. So yeah, so if you're bleeding, right, and there's just less blood in the system overall, there might not be more blood getting over to that left side to pump out. Okay. And when your left side's pumping out blood, you have to assume your left side is able to squeeze, yeah. So your left side has to be able to pump. Do you think it's harder or easier to pump against an aortic cannula flowing 5 liters per minute? Harder, yeah. So oftentimes if you have a sick LV and you put them on central, it can be tricky for that LV to pump against. Okay. So with those, some things when you see that pulse pressure drop, some things you might want to think about. I don't know why autocorrect's being weird, but increase inotropy, give some volume, or even sometimes consider decreasing your ECMO flows because you're going to decrease that afterload that LV is pumping against.
Perfect. I just
You
gave it
could-
that
you
guess.
could also-
Oh!
I just gave it like-
Oh my, yeah, oh lordy lord. Yeah, so this person did not have a vent. Or you could convince surgeon to put in a vent.
Yeah.
That would be the other thing. So you do all these things other than drop the flows because you're already struggling with pressures and all that sort of stuff. And nothing changes, like nothing changes. You crank your epi up to 0.2, you've given now like a bunch of blood prot, nothing has changed. What do you want to do next? Tea. All right. And you drop your probe and you think to yourself, what the hell am I looking at? What the hell am I looking at? Right? Because that's what you always think. What the hell am I looking at? So let's try to orient yourself because that's what you have to do is try to orient yourself. What am I looking at? All right, so we're at 0 degrees. So what more than likely view are we attempting to get here? 4-chamber, okay. Do we see anything? And remember, someone who's had valve replacements also is tricky because they're going to have all that dropout artifact. So what do we see anything that looks like anything we could identify anatomically?
Yeah, left
A hint of a valve.
Both sides have a little.
Okay.
hints.
So are we saying this is one of the little hints?
Yeah, maybe try that.
Okay, tricuspid.
Maybe mitral there.
Mitral, yep, and you can actually use the fact that she's had a mitral valve replacement to orient you, because this is probably one of her mitral valve struts, and this is probably her other mitral valve strut. You see how those drop out right there?
Yeah.
Okay, so this would probably be intraventricular septum, maybe around here. What would that make this chamber up here? Okay. What's abnormal about that?
There's a big clot sitting over the valve.
There's a big clot sitting over the valves. I promise I didn't try to make this clot like a clot lecture, but there's just a lot of surprises in the CV. All right, so now we've moved to 90 degrees. So what view are we probably looking at? Two chamber. And you can see again these nice little like dropout artifacts from the struts. And again, big old clot sitting on top of that mitral. And does it look like that mitral is really opening?
No.
No. Would that explain why doing all those things has not helped? And now what view are we probably looking at? Look at your omniplane to help you. Not RV. So you know this clot's still up here in the LA, right? What does this look like here?
Metasophageal long axis.
Long axis view. Yep. So, and it's hard because she had double valves. So there's just going to be a lot of dropout that obscures stuff in your far field. So you can see, does that aortic valve look like it's opening much? Not really. And then this is your transgastric. And what does this kind of look like all up here around? Clot. And you can see the lumen here of the LV, right? Like it's really not filled, but it's a very thick LV. All right. What would you like to do? Of course, this happened also at 2 in the morning.
Yeah.
Only 2 in the morning.
Send them back to the OR.
Back to the OR. Yeah. So she ended up, we started a heparin drip. There was a lot of, luckily it was only it wasn't at 2 in the morning. It was like 5.
Yeah.
Everyone's like, she needs to go back to the OR emergently. And I'm like, I think this is going to require some discussion.
Yeah.
She ended up going back, and I think she didn't do well, and family opted to stop. So
So I guess what was the thought about the etiology of this?
so she was hemorrhaging after her ASD repair. And her whole thing was really complex, and I didn't want to get into the whole thing, but the ASD is what I think could become a case report. So she wasn't on heparin, and with the mechanical valves and the really sluggish flow through the valves, because she was on ECMO, that they actually think she probably started forming clot pretty close after going on ECMO. And then because of the sluggish flow, it just built up from there. All right. This next one's easier. What procedure is the following person likely having done? And we can look at all the clips. So we'll look at this clip.
Well, having a TE done.
She's having a TE done. Perfect.
I mean, we can send her to probably also in the hospital.
All right. We'll look at this. Anything stand out? Just even basically. Doesn't look terrible. All right. What about here?
Need something done. Right? Definitely compensated.
All right. Here's the ready. Here we go.
Something is missing.
Something's missing. And it's something that would lead to a bigger RV like this lady has. Yeah. What septum is she missing? Yeah.
This is RV and flow outflow.
This is RV and flow outflow.
Yeah, so that, yeah, atrial.
So usually what's right here,
Yeah, okay.
right? Because remember when we were looking at those clot pictures, how we saw the clot kind of like sitting right here?
Was there evidence on any of the other images?
They're the 4-chamber. Yeah, this one right here.
There's nothing up there.
Oh, yeah, look at that.
Yeah.
Now it looks obvious.
Exactly. And usually these people, they follow them, and then eventually they'll start getting a dilated RV. So you can see her RV is a little bit big compared to that left side. So yeah, she's coming in for an ASD repair. It's always easier to spot abnormal things than missing things. All right. And now we've got another one. What's going on with this patient? I think this was your patient the other night.
Oh, is it?
Yeah.
We're doing this T.
Dissection.
It might have been.
All right. What view are we looking at?
Yeah.
So what views are probably around like 120, 140-ish?
Mid-esophageal long axis.
Mid-esophageal long axis. Yep. So it's a little bit swung over, but here would be your LV. Here's your mitral. Here's your LA. Here's your RV. And what vessel would make this then?
Aorta.
Which lumen are you talking about?
So that's going to be your aorta. And what is going on with this aorta? Yeah, so you got a dissection going on. So this patient has a type A dissection. And what pathology do you think is also going on with this type A, looking at this valve? So it's one of the 3 things that'll kill you with the type A. What do you think about this aortic valve?
It's like bowing sort of back.
Yeah, do you think it's coapting well, probably? No. So acute AI is going to be one of the things that will kill you with the type A. This is another thing that will kill you with the type A. So what is going on in this picture? This patient does not have 2 hearts.
Tamponade.
Tamponade. Yeah, so this is a transgastric. So you're at 0. Here's your LV. Here's your RV. And this is all clot. They might have been doing CPR right now. I'm not sure, but yeah, so tamponade, acute AI, severe AI, and then dissecting a coronary.
So
So
down on the table.
yeah,
Yeah, that was Saturday.
yeah. So these are one of the 3 things that'll kill you with a type A. All right. Oh, this is good. If we get through this one, we'll be good. All right. This is another patient, a 70-year-old man. He recently had a stroke, thought to be due to a PFO, resulting in some vision loss. He has known severe aortic stenosis and bilateral PEs, and he presents via the shot call system for consideration for an emergent AVR. Basically, at the other hospital, he started to decompensate. He was on high-dose dobutamine, had worsening renal failure, and just worsening pulmonary edema. So they know this man has tight valve. He wants to transfer here. And he gets accepted, and he actually gets accepted to go straight to the OR, which never happens except in this case. And you put the probe in. This is what you see. And we'll just look at all the pictures. This is our 4-chamber view here. And I took these pictures, so I always do like a very systematic thing when I get pictures. All right. So we'll look for some MR. What do we see kind of sneaking into view here? Yep. So this is your LVOT. And then what would that turbulent flow coming in the LVOT? It looks like during diastole. Regurg, yeah. So we know this guy has AS, but it looks like he might also have some regurg. So this is a little tricky to see up here. Actually, why didn't we turn the lights down? That was dumb of us. So what view is this going to be? Long axis, okay. So we see, oh God, that's so much easier.
You did.
So you have your LA here, your LV, big LV, and then what's this here?
That's your, well, where normally the aortic valve was.
Yeah.
It's very.
Does that look like a normal aortic valve?
No, it's very thick and.
Does that look like just a calcified aortic valve? Right, we looked at some calcified valves. Or does that just look weird?
It's just.
It looks weird, okay. All right, so we're gonna put some color on.
Bad news. A lot of yellow.
So a lot of yellow. So we knew he had severe AS, but what also does he probably have?
Yeah.
AI, some pretty bad AI. Okay, and we get some better pictures of it. What do we think? Does that just look like a calcified valve? No. What would you be suspicious that's going on with this patient?
The vegetation, like endocarditis.
Yeah, so some sort of vegetation. Right, because this guy wasn't doing well at the outside hospital, but like seemed like he decompensated more than someone with just AS. And then what do we think? So that what view is this?
Inflow, outflow.
Kind of inflow, outflow, or
High
aortic valve,
cable.
or aortic valve
Aortic
short access.
yeah.
Yeah, because we're a little closer to 30 than the 60. But, and what do we think about this valve? I think we'd probably like to see it with some color on too. And then what we can sometimes see out here, what vessel can we sometimes see associated with this cusp? One of the coronaries. Okay, what coronary would it be? Based on the cusps. So what part of the heart is this? What ventricle's down here? RV. So what cusp is this? Match.
The right.
Right coronary cusp. Yep, yep. And then I always think, what's up here? LA. Yep. So what cusp is this? So that's going to be your left coronary cusp. And then I always think this cusp is non-coronary because it's right by the septum. It has no loyalties. So this could be your left coronary here. But Dustin, does that look like a normal left coronary?
No.
Looks big, right?
Yeah, it's bigger than usual.
So yeah, if you guys thought something looked a little funky, which you guys said endocarditis, this was from the op note. So he had a golf ball sized abscess just under the left ostium, which basically destroyed the entire left coronary cusp and annulus. So it looked weird. It looked more than just like a calcified valve because it was.
Is that Milto's words?
No, this was a guy that I didn't want to take to the OR because I thought he was dead.
Uh-huh.
Like he just arrived looking dead.
Mhm.
We get him to the OR, we intubate, he was already tubed. We put our lines in, we're waiting, they're starting to wash the chest and he codes.
And
He just
codes.
like breathes down
Oh.
codes. We do compressions, we get him back, and then the surgeon looks at me and goes, well, and I'm like, no, we're here, you wanted this, we're
Yeah.
doing this.
Yeah.
He survived.
You survived?
He survived. Just ended up with renal failure, but he survived. The only thing we did with this is we switched his antibiotics in the OR
Mhm.
and sent some cultures. So, but something to do if it doesn't make sense, the whole story. And then this last one, this is a good one. 19-year-old male, no past
Another
medical
case
history. This is a case report. Yeah. We needed something more exciting than just
Yeah.
like, look at the mitral valve's leaky. He had a necrotizing pneumonia and COVID. He was really sick when he came in, so he got cannulated for peripheral VA ECMO. You know nothing else about him. And with his nasty, nasty lungs, do you think you're going to get any surface images on him? No, we tried. They were poor. So we put the probe in, and this is what we see. So what view is this? Or chamber view, okay. And we're just going to go through the images. Does this look normal or abnormal? Abnormal. How abnormal? Extremely. Okay, perfect. And that's what I said too. I go, what the hell am I looking at? So then we put some color on it. I don't know why I didn't get the mitral. I think this one was looking at tricuspid. But the right side looks completely smushed. And maybe there's some pericardial fluid.
Yeah.
All right. So now we're going to go to long axis. And how does this movement look? Normal or abnormal? Yeah, I thought it looked like the movement of the heart was coming from outside the heart. Like someone was almost doing CPR. Okay, so abnormal. And then what view is this? Inflow, outflow. And how does this look?
Odd.
Odd. The only way I could describe it is it looked like someone was pushing on the heart externally. And then I go down to the stomach and I see this. And I'm like,
The movement is just not natural.
no. I called a couple friends and nobody knew. And then I saw this. And again, what the hell is going on? And again, I think this was during the night. All right. So what do you think is going on? Adam, you can't respond because I think you're on this case report.
Yeah, I was there for that one.
Thoughts? I had no idea.
What's the time course of all this?
We called
Basically,
tweet like
he came
on our
in, you're just
FaceTime.
doing an echo to kind of see how things look on peripheral ECMO because he still had pressure requirement and stuff like that. And you wanted to know if you had to worry about north-south syndrome with a well-functioning heart. So I had no idea. I said, I don't know, but leaving this TE probe in a patient is not going to solve my confusion. So we took it out, we put an OG in, and then we got a KUB. You can see his necrotizing pneumonia. But what else?
It looks like he has left chest is like very odd looking.
Okay,
Aim for that. Like,
yeah, I
Is that,
big name.
was gonna say, this is like a trauma-based special.
I mean, does he have diaphragmatic injury somehow? Like almost like a bowel loop up in the left chest, but there's
It's
something.
not. I don't think that's it. But what is missing in like half of his left chest? His lung. Oh yeah, what does he have?
Is this just tension pneumothorax?
He's got a giant
Pneumo.
pneumo. He's got a giant pneumo that would probably, because you can see here, here's the curvature of his lung. So he's got a pneumo that probably, if he wasn't on ECMO, would leave him dead, or at least crashing, right? So yeah, that's when I learned that this is what a giant pneumo looks like on TE. We just never see it because
Never, yeah.
usually patients aren't stable enough to visualize it. That's why this was the last case of the day. But if you're ever down in the ED and they're doing an echo for CPR and you get ROSC and then you see this, I would get ready with a chest tube. So yeah. That's it. That's all I got. And see, we did finish early.
Yeah, it's perfect timing.
That never happens. Yes, we started early, but then we had AV. Any questions from those at home? Or wherever you are, probably not home, but wherever you are. All right. Well, thank you guys.
Probably.
Yeah.
Thank you.
No. All right. Should I exit out? I'm gonna stop sharing. No, the reason why I think that should be a case report is an iatrogenic ASD.
Yeah.
But there's like not a lot of literature out there about acute ASDs.
Mhm.
Well, normally they're in cardiology.